always say this, women are lucky that we have a menstrual cycle. Yes, I know some women are, I don't have a menstrual cycle, but it is our signal for health because the same thing can happen in men. It usually isn't until they fracture or until they try to have their partner get pregnant that they realize that there's an infertility issue. This is where women's health has an advantage that we do have a menstrual cycle to actually monitor every month and understand that pattern.
Hello, everyone, and welcome back to the Thick Thighs Save Lives podcast. I'm Kelsey.
And I'm Rachel. Guys, we have the hormone episode you have been waiting for. If you are a woman, this is for you. If you know a woman, this is for you. We have the be-all, end-all of experts on hormone health. Chrisandra Shufelt is a professor and chair of the Division of General Internal Medicine at the Mayo Clinic. You're in Jacksonville, right, Chrisandra?
Correct, yes, Florida.
And she is also the associate director of the Women's Health Research Center for Mayo Clinic Enterprise. She is a health internist for women, a certified menopause practitioner, and the president. Guys, we brought you the president of the Menopause Society, okay? You guys asked, we delivered. You want to know everything about hormone health, and you have not been given the access. And we know, having spoken to our community, that they feel that this topic is very undereducated for the typical woman. So we brought you the best of the best. She's got 200 publications in women's health and has co-authored a ton of scientific position statements on both menopause and hormone therapy. So the best of the best, Chrisandra, thank you so much for being here. Welcome to the podcast.
Thank you for having me. Thank you for having me. And it's a passionate topic of mine. And I think at the end of the day, everyone needs to know about hormones, whether it's whether when you start your period versus when you end your period and everything in between. So I'm really excited to have this opportunity to talk. And I will say I am now the past president of the Menopause Society. I finished my reign, and that culminated with the non-hormone position statement. So we can talk a little bit about how we treat hot flashes too. But it's an excellent opportunity to also advise your audience that if you ever need information about menopause, it's menopause.org. It's an easy, simple URL, menopause.org, and that is the Menopause Society's scientific website that's got evidence-based, real academic research for menopause. It's got questions and answers. It's got a patient front website as well as a doctor front website. So it's a great resource.
Absolutely. I know that, women have a ton of questions about so many stages of our life with hormones that this is changing all the time. So even if you feel like you had a good handle of your hormones at one point in your life and then you're like, what's going on now? Now these are all new. Like, how do I navigate this space? So you're clearly the authority when it comes to women's hormone health and all the points of their life. What got you initially interested in this topic and making it your life's work?
Oh, that's a great question. After medical school, I trained in internal medicine. And when I did my rotations, I would be on different cardiology or gastroenterology, GI, which is your stomach. And I'd be on these different services rotating through and really started to see women present with different complaints or conditions. And I just realized that there's a difference between men's health and women's health. And that really drew me to understand really sex differences in research. And at the time that I finished my training, there was a lot of confusion around menopause care, and women were being told to not take hormone therapy. And that really drew also my interest in women's health. And I wasn't interested in OBGYN. That's a specialty in women's health in terms of surgical specialty, which I likely call bikini medicine, right? They deal with a lot of the reproductive organs. I was really drawn more to what is the impact on estrogen throughout the whole body of a woman. And it's not just about, the menstrual cycle is a vital sign. That's important to note. But I was really interested in, and what I really came out to do was cardiology research, and that was specifically how men and women are different when it comes to cardiovascular health.
I mean, for years, we have been medically sort of treated in the exact same fashion.
Hmm.
A person is a person, and when they come in with symptoms A, B, and C, most likely, and all of especially in the fitness and health industry, all of the research sort of being based on a man's body
Hmm.
and how a man's body reacts to this, and how and all the studies is it's so refreshing to hear that you say you saw this hole in the field and you wanted to address it, and then you went on and addressed it in such a major way that has made such a giant difference for women's health. It's very inspirational, and just obviously
Thank
we want to
you.
thank you for the work that you've done. um, we love the idea of the education and then the re-education of women based on their changing hormone health. We're not waking up in the same body every single day, and that is knowledge that is power. As far as younger women, let's hit the younger women for a minute, where we're talking about like get your period to maybe like early 20s, 25, that kind of stage of your hormone health. What's the most important message you could give young girls and young women at this stage in their life regarding their hormone health?
Again, a great question. And I think I likened it back to the fact that, we take blood pressure, we take, pulse, we check your breathing, respiration rate, but nobody really asks about the menstrual cycle. And women are unique in that we have a menstrual cycle. And the last time you might have been asked about it was when you were at your OBGYN's office. And really, the idea is to make sure to really screen for pregnancy. But ultimately, at the end of the day, it is a vital sign because we need to know the characteristics. Is it happening every month? Is it regular? Because that is the key to a lot of female specific disorders is how regular your or irregular your menstrual cycle is. And really, one of my key areas of interest is the area of exercise in women, and more specifically, overexercise in women. And there is a condition that can shut down the menstrual cycle from overexercise, undereating, or really disordered eating, and then stress. It's really caused by those three, a combination or even an individual one, but they really do overlap with each other. But it is a condition that actually starts in the brain and it shuts down the ovary to make estrogen. So this is a condition that happens in young women. The average age is about 25, 26, but it really is defined as missing 3 or more months of a period. Now, there could be a lot of reasons that women miss menstrual cycles, but if someone is over exercising or under eating or is very stressed, that could be one of the causes. And while estrogen is low in this situation because you're not making estrogen, the ovary kind of is on strike. They're saying, "Look, you're not healthy enough in terms of carrying a child. We're going to stop estrogen production. We're not going to ovulate." Technically, women are infertile during this period, but it is beyond just estrogen because what happens is the body also accelerates the stress axis. And so these women are walking around with higher cortisol. So it's low estrogen in the setting of high cortisol. So, unlike natural menopause, which is the other spectrum where women lose estrogen because it's a natural, normal phase of a woman's life, this is not a natural phase of a woman's life because it is actually being a forced signal from the brain to close down the ovary, lower the estrogen, and raise and really go increase the cortisol. And there's also some other hormones that get disrupted too, like thyroid. So that's an interest of mine in terms of what we're doing for what we're looking at for the younger women because we know, and you might have heard this term, the athletic triad, or the female athletic triad, but it extends beyond athletes too, because it happens also in a lot of professional women as well, as areas because of the stress that's involved. But I will say that we do know that women in this situation, we start to see bone loss occur. We start to see, because estrogen is protective for the bone, and we are really just starting to look at what other areas of the body can be affected. And specifically, we're looking actually at the heart, because having low estrogen and high cortisol, how does that impact the heart health of young women?
That brings up a really good point, because I think that a lot of women who have kind of like missed or lost their periods during these times don't understand that it's not just associated with this like extreme exercise. I know that I've worked with women who have been like, well, I'm not working out like that hard or whatever, or like it can't be like that much. But when you combine that with a low caloric intake, which a lot of women do at the same time as they're starting an exercise routine, they lower their calories and to a point where it's not sustainable, or they're under a higher level of stress during those times anyway. So I think that's a really good point, that there are several touch points that can cause this disruption in your body that is essentially very harmful for women.
No, it's a really good point, and I think we underestimate the level of stress in our society
Yes.
and the impact that we are now seeing post-pandemic, right? Everybody's seen the impact post-pandemic, but if you look at who actually has had the most impact to stress after the pandemic, and who actually changed behaviors,
Yeah.
and those are the people, are women and men in Gen Z, the millennials. And then I would liken the fact that you couple that with social media. Social media has done us a tremendous of good, getting information out just like this podcast, and actually being able to really on a daily basis impact individuals who read social media. But on the other side, social media has created actually a lot of stress in individuals' lives. And believe it or not, there's a term called doom scrolling,
Yeah. Oh, yeah.
where
Very
where
familiar with
you
it.
very familiar, right?
Yeah.
So
We
so
did
I
a whole podcast on
oh yeah.
it.
Well, I guess when I speak to doctors, they all look at me sideways because they don't know that terminology. So it's enlightening that your audience would know that term, because I think it is important, because the impact of social media has it's twofold.
Yeah, absolutely. I mean, the amount of stress, it's almost like people aren't realizing or taking into account that there are higher levels of stress when we're bringing social media into our homes and into our everyday lives and into the second that we wake up and the moment we fall asleep, is that we're never actually leaving the stressful situations. We're never actually, it's not like you leave work and then it's done. Like, social media is causing a lot of people, I agree with you, it's like twofold of like, there's a ton of information, there's so much good that we can do or use from this tool that we have, and there's also a ton of harm. Whereas, like, where can we use this information? How can we use this tool to our advantage and not to our detriment, not to our harm? And it's like it never ends. Like, that anxiety is just elongating from the point of like, you wake up, you check your phone, you're feeling anxious about work, you check your emails, whatever. It starts from that moment, and then sometimes it's the last thing we do before we go to bed.
Right?
Like, let's be serious. Like,
Yeah.
we're in our beds, we're scrolling, we're doom scrolling, or we're checking our emails, and we're like ending with that level of stress that our bodies are really just not meant to carry. And that is definitely predominantly affecting women. And I know you do a lot of specific work with FHA. Can you explain what that condition is and the potential harm that it has on a woman's body?
Yeah, so FHA, for your audience, stands, it's a long name, very winded, functional hypothalamic amenorrhea. So amenorrhea is when you stop your menstrual cycles. It's functional because it's reversible. That's the great news. And it's hypothalamic because it starts in the area of the brain called the hypothalamus, which is really a control tower. It sends signals throughout your whole body to control different organs. In this situation, it's closing down the ovary from making estrogen and telling your adrenal gland to make cortisol. and as well as some other hormones. But really, functional hypothalamic amenorrhea, or FHA or HA, it's really responsible for about one third of the reasons why women stop their menstrual cycles. Um, Pregnancy is the most common reason why women stop their menstrual cycles. And then FHA and a condition called polycystic ovary syndrome, which is on the other spectrum of FHA, they pretty much are even in terms of the reasons why women will stop having their menstrual cycles. So, as I mentioned, HA or FHA is really defined after you've ruled everything else out, right? They rule out pregnancy, you rule out high testosterone that's associated with polycystic ovary syndrome and other conditions. And what you come down to is hormones that show low estrogen and low other signals from the hypothalamus, which is a luteinizing hormone and follicle stimulating hormone. These are the ovary signals. And we start to see that the no menstrual cycles for 3 or more months, as I mentioned. So that's the clustering of signs that we see associated with it. But we need to go back a step and say, well, what's causing this? The ovary just doesn't shut off. And again, it mentioned it was overexercise, under eating or restricted eating, and stress. So that really doesn't have to do with eating disorders. I mean, certainly that can encompass this, but in the studies that we've done, and we've looked at women with FHA and compared them to regularly age matched menstrual cycles, women that are getting their regular menstrual cycles, it doesn't even have to do with decreased calorie intake. Oftentimes these women have very similar calorie intakes, but the content of what they're eating is very disrupted at the times that they're eating. They're going long periods of times without eating, coupled with extreme levels of exercise. And that's one of the studies we're looking at right now, is actually incorporating Fitbit technology to look at exercise patterns in women who have shut down the menstrual cycle. Because if you look at the last decade of research, and this is an easy thing to do, you can go on to our archives of research in PubMed. In the last decade, there's been only about 180 original studies published on this subject. So we are well behind understanding this condition in women. And I mentioned early on that we know that there's bone loss that occurs, but we also don't know the implications of all these other hormonal changes on other parts of the body. And that's where we started to look at the heart and what we call vascular health or vascular function. And we've seen a small signal. It's about 1 in every 3 women with this condition have vascular dysfunction. And what endothelial dysfunction specifically, what that is every single blood vessel in our body, there's one cell lining, and it is the ability of that blood vessel to open and close to demand. Whether you're exercising, whether you're stressed, whether you're running away from a bear, you need that ability to open up those blood vessels. And the endothelium is controlling the ability to open it up. So what we've found is that 1 in every 3 women with this condition, we haven't seen the ability of the blood vessels to dilate as good as they should be. So if you were to find a rubber band in one of your drawers and open it up, you see how stretchy that rubber band is. That can equate to a very healthy endothelium. If you find a rubber band in the back of your drawer that's a little bit older, sometimes you can't stretch it as good. And that's what's happening in this situation. It probably is coupled with the fact that estrogen promotes the ability of blood vessels to dilate. And so if women don't have estrogen, that is probably not helping our blood vessels dilate, coupled with the fact that cortisol, stress hormones, can also play an impact on that lining of that blood vessel. But why is that important? Well, the good news is that this is reversible at this stage. Likely, if you reverse the condition, those women that we see this signal, that rubber band can go back. We haven't finalized that scientifically, but it is considered an early stage of cardiovascular health that we feel is reversible. It's like the first domino in the cascade. So if you stop that first domino, your heart health is going to go back. But I think it's an interesting find, is an important finding because so much has been focused on bone health, but we actually need to look at the total woman and say, are there other implications of having this condition in your body? Because ultimately, these women look physically healthy, physically fit, very healthy. And I think there's a bias in our society to say, you look good, you look healthy. Okay, you're not getting your menstrual cycle. Here's a birth control pill, but we're not treating the underlying condition.
You know what's really just funny, I guess, not funny, haha, but interesting about what you just said is years ago when I was in college, this happened to me, and my doctor's that you have amenorrhea, like this is what's going on, and we are like, okay, and she's like, I think we should just change your birth control. And that was it. I never heard anything about cardiovascular health. I never heard anything about my diet. It was like you're working out too much. It was definitely coupled with an eating disorder at the time, but physically I looked healthy. And the answer to that was, let's just change your birth control. Now, research has come a long way since then because I'm well out of my 20s. But so it's come a long way since then. But I think that that's kind of the care that we're used to when it comes to this discussion, when it comes to like some irregularities in our periods, or when it comes to like if we are presenting with some symptoms when we go to the doctor's office and we appear to be healthy. We appear to be in a healthy stage, and it's just kind of like, well, maybe we could just give you some more birth control.
And thank you for sharing that, Kelsey. I think that's really an important point, is that this is a really common condition. I think it's more common than we give it credit for. And we also don't even know, we don't I we can estimate that it's 35% of one third of women, the reason women stop their periods. But you take into account all of what we talked about with the stress going up in our society, the pressures going up on women, the challenges we might be facing with women's health as we go forward. And it actually, you know, it could be even more. We just started an international registry, an online international registry. So if you have this condition and you're anywhere in the world with a diagnosis, and if you don't have a diagnosis, we provide a kit to get labs done so we can confirm the diagnosis and rule out other causes. But we are getting women from all around the world in all walks of life. So these are women from Japan, from Australia, throughout Europe, that are now registering for this research registry to get a better understanding of this condition. Because at the end of the day, I think exercise is a component of it, but we really need to really have a better understanding of what causes it, what reverses it. I mean, ultimately, we need to educate doctors too, and not just put a band-aid on it by, here's another birth control pill and we'll get your period back, because that really is a false period. It's a fake period because it's a form of giving a woman back hormones to create a period, but it really doesn't then treat the underlying condition or the causes. That's not treating stress. That's not treating disordered eating or restrictive eating or overexercise. So I think by gathering this information and really collectively understanding how women get to this point, will help us then get to a better understanding of how we treat it and probably change guidelines.
Surprise! It's time for some holiday magic in today's surprise drop.
I love a good theme. I really love a good theme. So we have a couple different themes working for this afternoon
Don't tell them.
surprise drop. I'm not going to tell you what it is, but I do think that some of the Christmas lovers are going to be really excited about this.
Hell yeah. If you've got a turkey trot or you love Christmas, make sure you are on constantlyvariedgear.com today for our surprise drop this afternoon. We're not telling you what it is, but I'm just saying, if you got the thermals that were just released, cute matchups. If you didn't get the thermals that were just released, what are you doing?
What are you doing? Perfect matchups. Everyone who has gotten these thermals in the past has just said, I wish I got them in more colors. So don't let that be you. Go to constantlyvariedgear.com and pick up all your goodies today.
It's every single time women's health has any kind of a leap with regards to research and availability and education. In my heart, it just feels, it grows two sizes. I'm like the Grinch.
You're the
Um,
Grinch.
I wanted to hit on something that you had mentioned, and we did say, that this condition isn't always associated with disordered eating. Sometimes it can be, but it's not just a caloric game. It is really nutritionally based. And I wanted to ask you, especially with the rise that we're seeing right now in weight loss drugs, semaglutides like Ozempic, and the popularity of diet plans like intermittent fasting. Um, how big a role does nutrition or lack thereof play in our overall hormone health?
Well, certainly it's a cause for this condition in terms of the menstrual cycle with this restriction. We actually have seen this condition as a result of the new weight loss drugs. So semaglutide and Ozempic, those are the same drugs, tirzepatide, where there is a threshold of weight loss that occurs that then shuts off the menstrual access. Now that's a little bit different. That's a medication-induced hypothalamic amenorrhea as opposed to stress restrictive eating. But I think we are just probably breaching the threshold on what could potentially be a larger issue in women's health when it comes to the pressures of losing weight and how that can impact your hormonal health. Now, I always say how that could impact your hormonal health because the point being is that when you don't have your period, you don't have estrogen in your body. You're not releasing and with this condition specifically, you're not ovulating every month or releasing an egg to get pregnant, so you're technically infertile. But we want to be sure that we understand the overall health that's going to happen. So sitting at this condition is not just about not having your period; it's about overall total health because that's where I come back to the menstrual cycle as a vital sign. So just like your blood pressure is your overall health, the menstrual cycle is your overall health. But I do think that these new medications, coupled with what we've just talked about with societal pressures, have have added to possibly what this condition is, how we're seeing this condition.
Yeah, that's the medications are top of mind kind of for us right now just because they've hit mainstream health and wellness so hard that it, they've hit so hard, especially with women, and there seems to be little research on the long-term effects and just the effects on hormonal health. So we know, weight loss in a short period of time is going to have a large effect on your hormones. But what are some of the other factors around that? Like, what can we do? Like, how do you know if this is a good fit for you? So it really has been top of mind of like how this is affecting women, and that it might just be more than, oh well, I just don't get my period anymore, and maybe like I'm not looking
And
to get pregnant.
hallelujah.
Yeah, I know that, like
I know,
a
right?
lot of what I've heard is kind of like, well, I'm not looking to get pregnant anyway, so like screw it.
Sweet.
And I'm like, yeah, I'm like, I don't know if like that's how
Is that how that works?
for the rest of your body. Like, I'm not sure that this is maybe overall beneficial. So what are so people who are looking into some of these weight loss drugs, what are maybe some of the questions that they could ask regarding their hormone health, or some of the things that they could look for when starting out in order to protect themselves?
Well, I think with these new drugs, and by the way, we're talking about an extreme use of them where you're losing a significant amount of weight loss, that you're actually stopping your menstrual cycle. Because I do think that these drugs have done a tremendous amount for overall obesity in our society, right? There's a really, this is why there was call to action. We've seen that there's been in obese individuals, especially with diabetes, these medications actually have more impact on cardiovascular protection, so protection for those individuals that also lose weight. We also know the profound impact of benefit when you do lose weight on diabetes and blood sugars. So I do want to put that out there that these drugs, when used properly for their purposes, have had a tremendous impact on health. And while we haven't seen the long-term health impact of it, we've seen a short-term benefit in terms of things like decreased use of medications for blood pressure, for diabetes, and overall health. So I think what we're talking about is when do you use them, in a non-obese individual to lose weight or to lose 10 or 20 pounds, or use them not as prescribed, perhaps an off-label use. And I think if individuals do that, there needs to be thought behind why they're using it, because we do need to think about what the impact is in women that are not obese or men that are not obese. And for women specifically, if it goes into the category of I'm skipping my periods or I haven't had a period for 3 months, then that's then having more of a negative impact on your overall health. So it could be getting there from weight loss medications. It could be getting there from stress. But again, it comes down, and I always say this: women are lucky that we have a menstrual cycle. Yes, I know it's not. Some women are, yeah, I don't have a menstrual cycle, but it is our signal for health, because the same thing can happen in men. Men also can shut down their their testosterone access. They don't have a menstrual cycle. If they have extreme stress or they have disordered eating, which men do, or they are extreme exercisers, it usually isn't until they fracture or until they try to have their partner get pregnant that they realize that there's an infertility issue. So, this is where women's health has an advantage, that we do have a menstrual cycle to actually monitor every month and understand that pattern.
I love that reframe for having a menstrual cycle. First of all,
All right.
I know Rachel
Fine.
is so mad at it because
Fine.
it really is such a great indicator of what's going on and what's happening with your body. And I know this is like the majority of women out there are like, are you kidding me right now? But it really is such a good indicator and an overall great way to track throughout the month how you're feeling. Like, you do have a lot of ups and downs, but if you have that regularity in your menstrual cycle, it can really help you maximize how your body is performing, how you're feeling. I've said this before in the podcast, but once I had a better understanding of my menstrual cycle and how I could train, how I could exercise, the energy that was appropriate for me during my menstrual cycle or during my cycles, it was a game changer for me.
Mhm, mhm.
It, like, just having that power and that knowledge and information and being able to use it in your advantage, because guys, it's gonna happen anyway.
Oh yeah, I'll be sure
We
to just.
might-
I'll just thank everyone on day one. I'll just make sure I'll send a big thank you card. Oh, I'm so thankful you're here again. Oh
Talking
my
about the girl
god.
who hasn't had a menstrual cycle in 7 months.
Yeah, yeah. We don't want to hear from you.
I'm
Thanks
just real
anyway.
thankful right
Yeah.
now.
Yeah, thanks anyways. You don't even know. Okay, I want to shift gears a little bit to perimenopause, because this is just an area where we hear so much from women about being A, undereducated, and B, overwhelmed, because
Mhm.
it's a lot. It's a lot. And then it's like one of those, like, everybody's different. So this might be you, but it might be the complete opposite of you. So if a woman feels that she has some symptoms consistent with perimenopause that are interrupting her quality of life, What would be your advice for some first steps? Where can we get started addressing some of these issues?
Yeah, so while I spend a lot of time talking about younger women, and that's really my research interest and my interest in trying to change guidelines, I am a menopause provider. That is who I see in the clinic. And Mayo Clinic has a women's menopause and sexual health clinic where we are all menopause practitioners and sexual health providers and discuss this day in day out. So I think it's important to really define what perimenopause is and really what menopause is, because until we start there, understanding what the symptoms are just as important as the timing. So menopause is defined as, specifically natural menopause, is 12 months of no period. And that is a natural, normal phase of an adult woman's life. And speaking of lifespan, half of a woman's life, adult life, will be spent in menopause. So it's not a specific point in time. It is transitioning to a phase of a woman's life. So usually 36 to 40 years of a woman's life is reproductive, and then the other half is in menopause. So and as opposed to young women who abruptly stop their periods and result in low estrogen, this is usually accompanied by the perimenopause or the menopause transition, which is a phase in to that final menstrual period. The perimenopause or the menopause transition is anywhere between 2 to 7 years before the final menstrual period. Now, the average age of menopause in the United States and in most developed countries is 52. So think back to 2 to 7 years before that. That means starting around 45, we can start having symptoms that are associated with with menopause. So this is when we start to see menstrual cycles can become irregular, they can become heavier, you could skip them, and no two women are the same, meaning no two women's symptoms are the same or menstrual cycle patterns until that final period are the same. We do, and we have seen women have extreme symptoms during perimenopause, and then after menopause, they go on and they're fine. And then the opposite's true. We see women don't have any symptoms, and then all of a sudden, they just bam, they had their last period, and then they have symptoms after menopause. What are the symptoms, and what are some of the early symptoms of perimenopause? It seems that the more common symptom that we start to see in early perimenopause is sleep disruption. We see that, 3 to 4 a.m. wake up call for no reason, and then you can't go back to sleep. So,
I hear that.
yeah, but but I will
in,
That's
in
a
a different
different
phase.
thing. That's a
yeah,
different
but I will also say,
thing.
well, that actually is a lot of women's health, because if you ask any woman that's had a child, that 3 a.m. wake up call is pretty ingrained in our body after you have a child. So, but it is a very disruptive sleep pattern that starts, and it can be accompanied with other things such as night sweats and hot flashes that occur during the day. Not all women have perimenopausal symptoms. A lot of these symptoms do arise, however, after menopause or your final menstrual period. And predominantly, those are the hot flashes and night sweats. Importantly, we have seen a lot of, and I will say, estrogen fluctuates. And so while during the reproductive years, when you were having a menstrual cycle every month, there's a nice rise and fall of estrogen. During perimenopause, we start to see the ovary is it's puttering out a little bit. It's not completely not making estrogen, but there can be months that your cycle looks exactly like it was when you were in your 20s, or there can be months where your estrogen starts to rise and then it falls off, and then it starts to rise up again and then it falls off. And I call this it is the roller coaster of hormones. And with those roller coaster of hormones, you get highs of estrogen and you can get lows of estrogen. And the lows of estrogen we have seen accompanied with things like hot flashes and night sweats. And the change in estrogens that are dramatically changed, we have also seen impact mood. And even if a woman has never had any anxiety or even frank depression in her lifetime, that can arise at perimenopause. So it's important to have a self check of your mood and how you're feeling and anxiety, and know that those might be associated with perimenopause. So those are really the hallmark early signs that we see associated with perimenopause, is the sleep as well as the mood changes. And then as you approach menopause, some women get their periods more sporadic. Some women, like I said, they abruptly stop their periods. There is no way to predict which woman will fall into which category to get there, or which woman will have which symptoms. And if you check your hormones during perimenopause, it's just like looking at the stock market today. Is it up or down? It's not going to help me tell you that you're in perimenopause, because the fact of the matter is you're not in menopause until you've gone 12 months without a period. And checking is really just a one time spot check. I will do it occasionally to rule out things like the opposite extreme, hypothalamic amenorrhea, or if I have women that have been on the birth control pill and then they go off and they haven't had their period. But at the end of the day, if a woman is in perimenopause, we really do treat the symptoms. And so those are the kind of the hallmark treatments that we treat here at the menopause program at Mayo Clinic, and also what we do see in perimenopause. I think a lot of providers and doctors, we are not educated on the perimenopausal phase. And I think a lot more attention now has been placed on that phase because it's also important for health trajectories. And what I mean by that is it's important for half of our lives will be spent in menopause, and what happens during perimenopause is important to pay attention to. So if you're noticing your blood pressure starting to go up, or you're noticing your cholesterol is going in the wrong direction, or you've never thought that you're starting to gain a little bit of weight, we oftentimes see that in perimenopause. And I also spend the time talking about what is associated with ovarian aging or menopause and what is just associated with real natural aging or just getting older. And but I see it as an opportunity for health prevention, and so that you can live 20, 30, 40 years beyond in your healthiest stage. And I think that that's really what's also key about perimenopause.
You brought up a really good point that was actually feeling a little bit shocking for me, is like that is half of our life.
Hmm.
Sometimes the language that we use to discuss menopause or even perimenopause is just like, that's that, like way at the end there. You don't need to worry about that. And it's really like, no, this is half of your life is spent here just as much as your reproductive years. So it's really important to get a hold of how we can live our best lives in this stage and put some focus there and not I know it's frustrating that no two women are the same or going to experience the same symptoms, because we kind of just want like some affirmation surrounding that with like, what is it, so is there a checklist, like what do, and then I know I'm perimenopausal or know I'm menopausal, and it's like, no, there really isn't like a checklist. I mean, you name some great symptoms, but when it comes to like no two women are the same, like these could be adjustments for you, or you could see none of these symptoms. But I think you brought up a great point about weight fluctuation, which a lot of our listeners want to hear a little bit more from. So some major concerns with perimenopause or menopausal women have changes in their body composition, and primarily excess fat around the midline.
Hmm.
Weight gain with no exercise or diet changes is something we hear about a lot, or general feelings of changes beyond their control. What advice might you give women who are frustrated um, and might be having trouble recognizing the body staring back at them?
Yeah, an important point, and a lot of times that is a common first complaint that women come in with is the weight. And I don't think we've given enough credit to women's health in terms of the weight gain that occurs in midlife. And while we certainly know that chronological aging after 40, we start to see weight shift and start to see weight go up. And I heard a really crummy fact that 25 extra calories a day equals 2 pounds per year, starting after the age of 45. So you add that on 10 pounds later, that puts you at 50. And then you're staring down looking at a scale that is 10 pounds heavier. And what happens with menopause and what I call ovarian aging is it is exactly what you said. It is laid down centrally. So women start to lose the pear shape and they start to go towards the apple shape where you've got, and they don't recognize their bodies. And I've heard that statement many times. in the clinic. And what I do then look at is, are there other symptoms that are precluding that woman from not sleeping? Because we know sleep has an important role in how we metabolize our food and how when we exercise, how we do. Or are you constantly in a jet lag mode? If you are waking up at 3 o'clock in the morning every night, can't go back to sleep, that's like, flying to here in Paris back every week. You're just constantly going into that jet lag mode, and then that's going to raise things like cortisol, and those are going to make it even more difficult to lose weight. So I do look at that, and I ask about other concomitant symptoms. I do focus on exercise, but I will tell you, while exercise is an important component of overall health, nutritional intake is as important. And
Yes.
nutritional intake, 80% of weight loss is nutrition, is diet. And and I look at things like, like where they're getting their calorie intake. We unfortunately see a large uptick in alcohol use in perimenopause, menopausal women. That is a lot of calories, but it doesn't necessarily mean that women could. That's just one component of it. Doesn't mean that that's the reason that you're gaining weight. But and then oftentimes I will have women see a weight loss specialist to see if getting on a medication would help them prevent things like their blood sugars going up or their blood pressures going up. So I think this is why menopausal health is so individualized, and it's not just about, okay, lose weight. It's not just about, make sure you're sleeping throughout the night. It is very individualized because every woman's a little bit different in terms of their overall symptoms. But I will share with you that giving women back hormones or putting them back on hormone therapy, it is a very weight neutral impact unless we're going to be treating the symptoms. Meaning, if I can treat hot flashes and night sweats and that woman that wants to go work out, that's a big change. That's when I see the weight loss occurs. Or if I can give them, if they're sleeping through the night, then that's a big change. But I think overall, that menopause hormone therapy or putting women on estrogen with progesterone if they have a uterus, we don't tend to see that as a weight loss mechanism. And some women come in to see me because they think that's the answer. And I think, especially during perimenopause, when you have the stock market of hormones fluctuating up and down, we actually know that there's that impact of symptoms associated with the highs of estrogen as well as the lows of estrogen. So, again, it comes down to really understanding the individual symptoms and treating that woman based on those.
Thank you for your honesty on that. I think, it's a hard pill to swallow.
It
That
is.
they're that but it's one of those that the more you know. And I want to round out the podcast with our last question on talking a little bit about the options, whether it be homeopathic or pharmaceutical. Can you give our listeners maybe some of your favorites when it comes to remedies that might alleviate some of the hormonal issues if they are negatively affecting a woman's life?
So these are current guidelines. So for the majority of women, menopause hormone therapy, which is the form of estrogen and then progesterone or progestin, is the most effective treatment for women at the time of menopause for their hot flashes, night sweats, as well as other symptoms. So, if you look at the overall benefits versus risks in women who are healthy and they're at the time of menopause and they're free of any contraindication for taking hormone therapy. We don't want women who've had a blood clot taking estrogen. We don't want women who've had an estrogen sensitive cancer, whether it's a breast cancer or an ovarian cancer, a uterine cancer, taking hormone therapy. Those are not recommended per guidelines. But for a majority of women that are at the time of menopause, we do recommend taking menopause hormone therapy, which is estrogen with progesterone. Now, if a woman's had a hysterectomy or just their uterus has been removed, then we can just use estrogen alone. So those are our current recommended guidelines, and those are what we usually treat the most commonly for hot flashes, night sweats, sleep disturbance, a lot of host of other things that are accompanied with the menopause symptoms. Now, if you give women menopause hormone therapy in perimenopause, if you give them back a little bit of estrogen, some women do better. But again, those women are still having and making estrogen. So they're fluctuating their estrogens. And most hormone therapy doses are much lower than what that woman is making. So in some women, we just need to treat the symptoms. In some women, we put in a progestin IUD, which is a device that sits in for protection, because it's also important to note that you can still ovulate during perimenopause and you can still get pregnant in perimenopause. So and oftentimes it's not a viable pregnancy, which can result in a lot of complications. But we do want women to note that, yes, you're still making estrogen in perimenopause, and we need to also think about a birth control pill, or a birth control method. And it might not necessarily be a birth control pill because after 45, we know the risks of blood clots go up on birth control pills. So it is not an easy it's not an easy one answer, but it is an overview on what we generally recommend. We have also written a position statement on the non-hormonal treatments for hot flashes and night sweats for women who can't go on estrogen. And there are some new medications that have come on the market more recently that do work effectively for the treatment of hot flashes and night sweats that are not estrogen therapy. So it's important to ask about those as well.
That's a great answer, and I didn't expect that you would come into like, here's a one size fits all for everyone.
Mhm.
And honestly, we have continuously cautioned our listeners for anyone who does say like, "Hey, I have the overall fix for all of these things that you are experiencing in your life, and here's what it is," because like that's the diet trap of not
I
recognizing
don't
that
know
every
you.
woman is they don't know you that every woman is so individual. But those are some really great guidelines for to start to just kind of like get a hold of what's happening with your body, where are you in this journey, and how can we utilize this information to figure out how you can work with your hormones or alleviate some of these symptoms that you might be having. So I know we covered a lot, but there's so much more to hear. And I want to give you an opportunity to let our listeners know where they can hear more from you or where else they can learn some of this information.
Absolutely. So I would first say that the menopause program is at Mayo Clinic, and we do see virtual visits if anyone's interested in understanding how to treat menopause and perimenopausal symptoms. I would also encourage your listeners to think about opportunities for research for women's health, because as we go forward, really, it's women helping women and changing guidelines for research. And if you have a condition where you've stopped your menstrual cycle or know someone that stopped their menstrual cycle due to FHA, we are actively recruiting for an NIH study. So this is funded by the government. Thankfully, our tax dollars at Good Work for Women's Health. And for more information, you can give us a call at 904 953 9805. We have two studies. One is all virtual. You don't have to, it's the registry. And then the other one is actually one specifically looking at Fitbits. We actually give a woman a Fitbit and follow them for 3 months in their exercise patterns. But we have travel stipends to visit our campus here in Florida. So I would encourage you to speak up if you have symptoms, talk to your provider, think about bettering women's health over the lifespan. And again, thank you so much for having me. And it's been such a pleasure not only to talk to both of you, but also really it hits home when you talk to a woman who've who's had this condition, and how that then has been so understudied and under-recognized. And I just thank you for letting me bring this to the forefront. And it's estrogen across the lifespan as I go forward.
Yeah. Yeah, thank you so much for coming on. This has been um, eye-opening in so many ways, and I think just so helpful in looking at the lifespan of our reproductive health and just of our hormone health, and like what does this look like, how can this change on you know on a monthly basis, but over the span of our lives, and how might we be able to, instead of fighting with our hormones, that's kind of what it historically has felt like, that every stage we get to, we're just trying to fight to get back to the one before, instead of working with our bodies and our changing bodies, and trying to figure out how we can live our best life and feel our best right now. So thank you so much for the work that you have been doing, and just for coming on and sharing so much valuable information with us. It's been incredible.
Thank you both. I really appreciate it.